I have no financial interests. The patient presented to us, a 24-year-old male resident of Delhi, presented to us with drooping of both the upper eyelids since 1 month, which increased in severity. The patient also has history of fever since 1 year with a waxing and a waning course. Also, the patient had drooping of both the upper eyelids since 1 month. It was associated with limitation of movements in both the eyes and was initially associated with diplopia. The patient also gave history of few episodes of vomiting and headache. Patient also gave history of hypersomnia. There is no history of diurnal variation in severity of ptosis or movement limitation, no history of trauma, decrease of vision or similar complaints, no history of weakness in any other part of the body. On general examination, the patient was conscious, cooperative, and oriented. The neurological examination revealed no sensory or motor deficit except for the ocular muscles. Deep tendon reflexes were normal and nuchal rigidity was present. On ocular examination, the patient had a vision of 6/9 in both the eyes, with a chin lift and a frontalis overaction, with no facial asymmetry. The patient had a severe ptosis with poor LPS action and absent Bell's phenomena. The patient had exotropia and hypotropia in both the eyes. Both the eyes had limitation in all the gazes except for the abduction and encyclotorsion seen on slit lamp. The patient had a mid-dilated 7 mm non-reacting pupil and the fundus was normal. Hematological examinations revealed a raised ESR of 48, rest being normal, a Mantoux test of 15 into 13 mm after 48 hours of inoculation with a normal chest X-ray. Cerebrospinal fluid analysis revealed a cell count of 25 cells per millimeter cube with 60% lymphocytes and 40% polymorphs with a glucose level of 6 mg per deciliter, protein being 280 mg per dl. The MRI revealed bilateral, lateral, third and fourth ventricle dilation, suggestive of a communicating hydrocephalus. Here, in this MRI, we can see multiple ring-enhancing lesions in the both cerebral hemispheres and also in the other cerebral hemispheres. You can also see exudate in the basal cistern in the perimesencephalic areas. All these findings suggested of bilateral third nerve palsy with tubercular meningitis with hydrocephalus. The patient was started on antitubercular treatment with steroids. The symptoms of headache, fever, and vomiting started resolving, and the patient is being followed up for further management. Atraumatic, isolated bilateral third nerve palsy could be because of central or peripheral causes. Central being midbrain stroke, mesencephalic lesion, neurosarcoidosis, and peripheral being diabetes, vasculitis, and infections. Third nerve palsy assessment involves detailed neurological examination with special importance to pupillary involvement. Whenever a patient has isolated third nerve palsy with bilateral pupillary involvement, we should think of we should localize it to the two areas, the mesencephalon or the subarachnoid space. Here in this anatomical diagram, which we can see this is the area where the two third nerves leave the midbrain. And this is the clinical MRI picture. We can see the exudates in the perimesencephalic areas, suggestive of the etiology and the anatomical correlation. Pupil involving third nerve palsy demands urgent CNS imaging to rule out any compressive cause like an aneurysm or a tumor. After a compressive cause is ruled out, inflammatory pathology should be considered as a causative condition. Concluding, tuberculosis is one of the most common infectious diseases in developing nations like India. Imaging is a must in a young patient with isolated bilateral third nerve palsy. Anatomical localization and clinical correlation is very important in cranial nerve palsy. Thank you.
So that was a good case. Did you basically, what was it, like a nuclear third nerve or an intranuclear third nerve?
Sir, a nuclear third nerve would have other associated features because there are very important structures around the nucleus, right? Red nucleus and the cerebral peduncle. So these findings on the neurological examination, there was no tremors or ataxia or any paralysis. So most probably whenever there is isolated third nerve palsy, we should think of a subarachnoid space, which we saw in the anatomical correlation around the midbrain as the nerves were leaving. So there were the exudates, and most probably because of the inflammation and direct involvement of the subarachnoid space and the pial vessels were involved. So most probably because And the patient also had hypersomnia, suggestive of the inflammation of the midbrain area leading to those symptoms.
So did you, this patient had problems since 1 year, isn't it?
He had on and off fever, sir.
On and off fever, the eye
Yes.
problems, the eye problems.
Sir, can you repeat, sir?
The ocular problem.
Yes, sir. Ocular problems he developed since 1 month, sir.
1 month. Okay, okay. So did you check for the vestibular-ocular reflex?
Sir, the patient was was not cooperative enough to check
You
for.
have to turn his head. That's all, left and right.
Yes,
just for the doll's eye reflex.
So, but
So
there was we tried that, but sir, we could not appreciate because of the movement limitations, sir. The only abduction was possible.
So in these cases, if you have a VOR, probably that will give you a clue what where the lesion is, because even if you have limitation and a VOR is positive, probably those are the cases where the intranuclear pathway is not involved.
Yes.
Anyway, that's nice. But how would you explain the pupillary dilatation in this case and bilateral?
Sir, as the pupillary fibers are in the periphery of the lesions, and the nerves leave in the subarachnoid space from the midbrain, so there were exudates, and so the pial vessels would be inflamed, and that will lead to ischemia and of the pial vessels which supply the pupillary fibers. That will explain the pupillary involvement.
So patient recovered ultimately. What happened?
No, sir. We tried to contact the patient, but actually, because of the hydrocephalitis, the patient couldn't be